a little bit of how I came to be writing about psychiatry. So I'm a journalist by background. I'm not a doctor. I've been writing and I was a newspaper reporter for a long time. My beat was medicine. I focused on covering medicine and science. For a while, I was director of publications at Harvard Medical School. So I was trained very much in traditional sort of approaches to medicine. The next study we had was done by Loren Mosher. He was head of schizophrenia studies at this time. His study was designed like this. You come into the emergency room, you're either treated in a hospital with drug, or you're taken to a house called the Soteria House, which is just staffed with people who can be with people who are in an extreme state. And the hope is that by being with people in the house, the psychosis will begin to abate naturally. The people were expected to cook, they were expected to bathe, and they were expected to participate in the house activities. There would be yoga, massage, that sort of thing. And this was not a no-use model. They would use benzodiazepines to help people restore sleep-wake cycles. And then if someone was not getting better after 3-4 weeks on their psychotic symptoms, they would then use antipsychotics. So it's a delayed use of antipsychotics. They reported that at the end of the 2 years, this experimental model produced better results. This study, by the way, actually ran for 10 years. And then they noticed that this was what they said about antipsychotic use. 42% never exposed to the drugs in 2 years, 39% used them temporarily, and 19% needed to be on the drugs continuously. What you see here is a model of drug use that is what might be called selective drug use. You're figuring out for whom and for how long the drugs benefit. That's opposed to our one-size-fits-all model that we embrace today. Again, what does he conclude? He concludes we need to rethink this. It looks like not putting people on drugs right away appears to be advantageous. We think the balance of risks and benefits needs to be re-examined. Okay, the third study was done in-house at the NIMH, at the hospital run by the National Institute of Mental Health. It was done by William Carpenter, who's still a famous US researcher. He had this comparison. He had 1-year data for a group of patients treated with drug, and now he's going to do 1-year data for people treated without drug, schizophrenia patients. A couple oddities. Those treated without drug actually were discharged sooner, quite surprising. They had a lower relapse rate without drug, and they suffered less from depression, blunted emotion, and retarded movements. And he raises this profound question. He's trying to deal with the research literature that seems so complicated. Do the drugs work over the short term? Yes. Once you're on the drugs, do you have a lower relapse rate if you stay on the drugs than coming off abruptly? Yes. That's the first part of this. But now, there's this data showing that the drugs appear to be, nevertheless, increasing the chronicity of the disorder. So he raises this. What if these patients had never been treated with drugs to begin with? We raise the possibility that antipsychotic medication may make some schizophrenic patients more vulnerable to future relapse than would be the case in the normal course of the illness. Here's why this is so worrisome. Every drug has benefits and risks, right? And we know that antipsychotics have a lot of risks, a lot of adverse effects. What he's worried about is the benefit side of the equation. Because the drugs are supposed to knock down psychosis over the long term. That's the benefit. But he's worried here that the drugs cause a biological change that make people more vulnerable to psychosis over the long term. At this point, someone steps forward with an explanation biologically for what they think is happening. This was done by Guy Chenard and Barry Jones at the McGill University of Montreal. And they said this. By this time, there was an understanding of how drugs worked, how antipsychotics worked. And real quickly, we know that the way neurons communicate in the brain, you have a presynaptic neuron. It releases a molecule we call a neurotransmitter into a tiny gap between neurons, which is called the synaptic cleft. And then that molecule binds with receptors on the receiving neuron, the postsynaptic neuron, like a key into a lock, and that's how messages are passed. Okay, and that's what you see here. Now, what they came to understand was that the first-generation antipsychotics, the way they worked is they blocked these receptors. They gummed up these locks. And because they blocked these receptors, dopamine could no longer find a docking site on the receiving neuron. And at a therapeutic dose, the old drugs block about 70% of a particular dopamine receptor called the D2 receptor. So that's how they work. And then researchers learned this. In response to that blockade, the brain undergoes adaptation. It tries to compensate for the presence of the drug. So an antipsychotic is putting down a brake on dopaminergic transmission, right? It's gumming up those locks. So the brain responds by trying to put down the accelerator on dopamine transmission. And it does so in two ways. For a time, the presynaptic neurons put out more dopamine than normal. Now, that compensatory adaptation doesn't last. It doesn't seem. The one that lasts is the postsynaptic neurons actually increase the density of their receptors for dopamine. They're trying to become super sensitive. This is well known, and what researchers say is the brain is trying to maintain its normal functioning or its normal homeostatic equilibrium. But what researchers said is, once you go on the drug, your brain is now super sensitive to dopamine, and that's what makes you more vulnerable to psychosis over the long term. And what's happening is the drugs are producing the opposite of the intended effect, okay? And they write this: neuroleptics can produce a dopamine supersensitivity that leads to psychotic symptoms. An implication is that the tendency towards psychotic relapse in a patient who has developed such a supersensitivity is determined by more than just the normal course of the illness. So they're saying that the drugs make people more biologically vulnerable to psychosis. Now they also studied, they did a study, does this vulnerability eventually become permanent? And you get something called tardive psychosis. And they looked at 216 outpatients, and they concluded that 30% now had become sort of permanently psychotic. And they had these more severe symptoms. And they said this developed at a rate of about 3% per year. In other words, after 1 year, about 3% of patients show tardive psychosis. After 2 years, 6%, et cetera. And they say when this happens, the illness appears worse than ever before. New symptoms of greater severity will appear. So this is the image of antipsychotics that begins to take place by the early 1980s, 30 years after we have these drugs. And you can see the pieces of the puzzle. You have clinicians' perceptions. You have some clinical studies. You have a retrospective study. The question is raised at the very heart of the NIMH. And now we have a biological explanation. Now, there are stories of Chouinard and Jones presenting their data to psychiatrists, and the psychiatrists basically unable to sort of process this information, sort of a cognitive dissonance. And there's a story of psychiatrists standing up, "Are you telling me that my drugs that I used to knock down psychosis are making people more psychotic over the long term?" And you can see why this is so threatening to the sort of psychiatric model. This is happening at the very time that the American Psychiatric Association is adopting the medical model with its issuing of its third volume of the Diagnostic and Statistical Manual. And basically, you see psychiatry push this aside. We're not going to worry about this anymore. Just remember this, okay? We're going to come back to a last study, and we're going to see whether we still have this worry, okay? Now, going forward 25 years, let's just look at another line of inquiry that was opened up. We get MRI technology that can study brain volumes. And one of the things that researchers do is they give the old drugs, and they give the new drugs, and they give the clozapine to animals, to monkeys. And they do it at a therapeutic dose. In other words, the dose is appropriate for the weight of the monkey compared to the dose that you'd have for a human. And they find that basically the brain shrinks over time. And that after 2 years, the weight, and then they sacrifice the animal, the monkeys, the brain weight is about 10% less than normal. And you'll see they conclude that you see this shrinkage or this difference in brain weights and brain volumes across all major regions of the brain. So obviously, the worry here is that maybe this is happening to humans too. Now, the best long-term MRI study we have in humans has been done by Nancy Andreasen. She's the former editor of the American Journal of Psychiatry, so this is someone in the mainstream psychiatry. She began a long-running MRI study of 500 newly diagnosed patients in the early 1990s, and her theory was this. Schizophrenia is a neurodegenerative disease characterized by brain volume loss over time. She thinks she's going to see a shrinkage of the brain due to the disease. Okay? That's her theory. And in 2003 and 2005, she says, that's what we see. These brains are shrinking over time of my patients. So she says schizophrenia is a progressive neurodevelopmental disorder characterized by this progressive reduction in frontal white matter volume. Okay, so she sees it in her patients. Next, she says, as this shrinkage occurs, the patient gets worse. You get an increase in emotional disengagement, you get increased functional impairment, and after 5 years, you get cognitive decline. So she's putting out a picture of a disease process. Something is causing the brain to shrink, and as that happens, people get worse. But now you see the dilemma, right? Is it the disease, or is it the drug, or both? So she looked at that question. And in 2011, she reported that the shrinkage was drug-related. You see use of the old drugs, the new drugs, and clozapine were all associated with smaller volumes, decreases in both white and gray matter, severity of illness and substance abuse had minimal or no effect on brain volumes. This is what she told the New York Times. What do these drugs do? They block basal activity. Basal ganglia relies on dopamine to work. That's what she means by that. And she says, what happens? It doesn't get input at noods, means shutdowns. It causes the prefrontal cortex to slowly atrophy. That's shrink. Now, if you ask Nancy Andreasen today, I think she would say this. There is still some shrinkage as part of the natural process. Maybe it's due to stress, who knows? And that the drugs, rather than stop that, exacerbate it. There have been research done, or a paper published by Joanne Moncrief of the UK and Jonathan Leo in the United States. They sought to answer this question. If you look at schizophrenia patients who've never placed on medications, never, do they show shrinkage? Now, I don't know how they managed to find such studies, but they found 3 such studies in the literature, MRI studies, where the patients, in fact, over the long term, had never been exposed to drugs. And in those studies, there was no significant difference between the brain volumes of those schizophrenia patients and the normal controls. I think this is still an open question of if there's any shrinkage as part of the disease process itself or the disorder process. But what's clear is, do the drugs shrink the brain? Yes. And the real problem is, as that shrinkage occurs, you see a worsening of the patient overall. And I think you can see why this is so troubling. It's really the story of an iatrogenic process. You have an outside agent, which you take, which causes a measurable change in the brain. And as that change happens, you see increased emotional lethargy, increased functional impairment, and cognitive decline. At least that's the worry that arises from this. Just a recent review, 43 brain imaging studies, the European research. This just came out last month, and they determined that the loss of volume was significantly more severe in medicated patients. So the data showing that the medications shrink the brain is becoming ever more solid. And by the way, a lot of the shrinkage happens in the first year. Okay, that's this. I mentioned the WHO cross-cultural studies, where the better outcomes were in the poor countries. You'll see this thing about strong predictor. You also note an exceptionally good social outcomes in the developing country. Here's the medication difference when they assessed it. They went back and looked at 15 to 20 years later, and in the poor countries where people had not been regularly maintained, noticed that 53% are no longer psychotic and 73% are working. We now have a new updated cross-cultural study. It's done by Eli Lilly, 11,000 patients in 37 countries. What's different about this study is everybody is kept on meds. Okay, so everybody is on meds for 3 years. Really 2 parts here. This actually is a lot of good symptom control, I'd say. You're actually seeing a lot of symptom control. What you're not seeing is good functional outcomes. You're not seeing people working well. And now, if you look at the parts, say North Africa, Middle East, East Asia, which were the developing countries in the old studies, which used to have very good functional outcomes, their functional outcomes have declined and are now actually worse than they are in North Europe. And it's not that the outcomes in basically Europe have come up. It's that the outcomes in the poor countries have come down as they've adopted this paradigm of care. So anyway, you see this, and the question is, well, why are their outcomes worse today, functional outcomes, as they maintain their patients on the drugs? Okay, real quickly. We have conventional wisdom, and conventional wisdom says these medications are absolutely essential for schizophrenia. I've told you a very short story about a different history of science that says really the drugs are making people, on the whole, worse over the long term. Now, we have one long-term study done in the United States that followed patients for 20 years. It was done by Martin Harrell at the University of Illinois. And what he did is this. He enrolled 200 psychotic patients into his study. And everybody is treated conventionally in the hospital with drugs. And then he just follows them at 2 years, 4.5, 7.5, 10, 15, and 20 years. The patients are discharged, and they're free to stay on the drugs or they're free to go off. And then he looks at medication usage, whether they're employed, etc. He ends up with 145 patients he follows for 15 years. 64 have a diagnosis of schizophrenia. 81 a diagnosis of a milder psychotic disorder. Here's his outcomes. This actually is the 20-year data. Anxiety, you'll notice this is of the 64 schizophrenia patients. 25 of the 64 patients actually quit their drugs in the first 2 years. So by the second year, they were off drugs. This would not happen today, but in the early 1980s, it was earlier to get off medication. This is really revealing. So the percentage with high anxiety is about the same at the end of 2 years. Those off drugs see this dramatic decrease in anxiety. Those on drugs, you actually see an increase in the percentage of patients with high anxiety. And the worry here is that the patients are developing something called tardive akathisia, a persistent inner agitation, a persistent inner anxiety. Akathisia is associated with suicide and violence. Okay, there's a strong association. It's also associated with poor outcomes. But anyway, you see a great difference in anxiety symptoms. Cognitive function, remember we said that the drugs after 5 years are associated with cognitive impairment. He found that every follow-up, those off medications had better cognitive function. Remember, we worried that the drugs would make people more psychotic over the long term because of the dopamine supersensitivity. That's what he found. He found that at the 10-year follow-up, for those who got off medication, only 23% were actively psychotic. 79% still had psychotic symptoms, those who were on their drugs. This is the global adjustment. Again, you'll see at the year 2, there's not much difference. It's the healing that you see between year 2 and 4.5 in the off-med group. This is the only place in the scientific literature where you see healing that takes place over an extended period of time. Nothing else tells us what can happen from year 2 to 4.5. Those other studies are all telling us what happens over the short term and what happens when you come off. But this is the reason for optimism. Look at this getting better, but it occurs later. Okay? Recovery rates. To be recovered in this study, you had to be asymptomatic at the follow-up. You couldn't have been hospitalized in the previous year. And most importantly, you have to be working or in school more than 50% of the time, and you have to have pretty good social functioning. At the end of 2 years, about 20% of those off medication were in recovery versus 6% of those off. Notice the recovery rate goes up between year 2 and 4.5, such that at the end of 4.5 years, 40% are in recovery off versus 5% on, an 8-fold higher recovery rate, and you see that's the way it stays for the 15 years. By the way, of those who got off medications, more than 50% were employed. Martin Harrell has 3 outcomes. He has recovered, so-so, uniformly poor. Among the off group, it's 40% recovered. This number is wrong. It should be 44%. Sorry about that. And then 16% uniformly poor. You'll see the on medication group, it's 5% recovered, 46% so-so, 49% uniformly poor. In other words, it's not just a lower recovery rate, but the on-med group has a lot more uniformly poor people. Now, if you read the study, Martin Harrell says this, his 15-year study. It's not that the medications make people worse. It's that the good prognosis, more of the people who got off had a better prognosis. So what we're really saying in this study is that you have a subset of patients with good prognosis who get stabilized in the medication, and that's the ones that are able to go off. But I said to him when I interviewed him, that's not what your data shows. And we'll talk about this in just a second. And what he said to me was this. He was told not to publish this data because it was bad for psychiatry, his colleagues. He could not get it published in the United States. He had to get it published in a British journal, even though this is one of our best-known researchers. And basically, he was saying that he had to spin his discussion. If you look at the outcomes for those in the good prognosis group, those off did better than those on in the good prognosis group. In the bad prognosis group, those off did better than those on, even in these subsets. Here's what he told the 2008 meeting of the American Psychiatric Association. I conclude that patients not on antipsychotic medication for a long period of time have significantly better global functioning than those on the drugs. This is the conclusion from the best long-running study we have. How many heard of this conclusion? Was it in your newspapers, your magazines? Is it in your training? This is the only prospective study that has really followed people over the long term. How about those with milder disorders? Again, the same thing. You see much better outcomes for those who got off. By the way, this is really good outcomes. Recovery was 1 or 2. The cumulative number was something like 2.4. The people who got off long term with milder disorders did really well. A lot of employment. Now here's the data, I think. If you want to look at one chart that you leave with, it's this one. First of all, schizophrenia on meds, other disorders on meds. These are your medication-compliant patients. These are your patients who are not doing what the doctors tell them to do. The best outcomes are the lower ones. And the most important thing is this. Why is schizophrenia off meds better than milder disorders on meds? These people at initial prognosis had a worse prognosis. So why do they have better long-term outcomes? Now, I only know one explanation, and that is that the drugs worsen the long-term outcomes. Maybe there's another explanation. I don't know it. That's my interpretation. But at the very least, since we as societies insist that people with psychotic disorders take these drugs, don't you think we should look at this chart and try to answer why people with schizophrenia off did better than milder disorders on, and why the care that we insist on produced the worst outcomes? Here's the summary. Those who stayed on antipsychotics, much more psychotic, much more anxious, had worse cognitive function, lower recovery rates, more likely to have uniformly poor outcomes, had worse global outcomes. This is pretty compelling data. Here's what he raises. The question at the end of 20 years, you can see it's a question raised by his data. Now, I'll end this talk real quickly. I think if you look at this data, you would use medications differently. You would try to avoid immediate use of medications because there would be a subset of patients that could get through the psychotic episode with psychosocial care. They wouldn't have these changes in the brain, and that would be the group that would have the best long-term outcomes. And then second, if you needed to use the drugs, you would figure out who needed to stay on them and who did not. Now, fortunately, there's a group in Finland, in Western Lapland, who practice a form of care called open dialogue therapy, which I think you've heard about. And they, beginning in 1992, adopted this protocol for medications, and they now have by far the best outcomes in the Western world. It shows the possibility, if you use drugs artfully, to get much better outcomes. And here's their outcomes with first episode psychotic patients. 5 years after initial diagnosis, 2/3 of their patients have never been exposed to antipsychotics. There's in essence 1/3 that have been exposed. Ongoing use is 20% at the end of 5 years. Look at the outcomes. 79% are asymptomatic. Only 20% have gone on to long-term disability. This is the group, this 80% that are back in the employment force. This unemployment rate is lower than it is for the Finnish population as a whole. It shows how good they are about getting people back to work. And I think in our, even though I don't speak hardly any Danish, no, I don't speak any Danish. I don't know a single word of Danish. But I had a translator who was saying, you know, one of the questions is, how do we get people back to work? all I can say is in northern Finland, they're achieving that goal. And it's really a model, I think, of science illuminating a better way. if we can open our minds to the science, which might be difficult. Now, if I had given this talk 5 years ago, it would have seemed sort of crazy, so radical. But here's what's happening. Within psychiatry itself, mainstream psychiatry, this data by Harrow and this other data is getting better known now. And just last month, or 2 months ago, the British Journal of Psychiatry wrote this. It's time to rethink the use of these drugs, that they should always be the first line of treatment. And they noticed this is not a wild cry from the distant output, but a considered opinion by influential researchers. In other words, people who've looked at this evidence base are changing their minds. And you can see there's an increasing body of evidence that the adverse effects of antipsychotic treatment are, to put it simply, not worth the candle. So you're hearing a talk here today that might seem radical, that might seem so contrary to everything you know that is true. But all I'm saying is other researchers, I'm not a researcher, but researchers who've looked at this body of evidence are saying we need to rethink this. And it's because when they focus on long term, they see a very different picture. I'm not going to go through the depression. Basically, if you look at the course of depression in the modern era, it has changed from an episodic to a chronic course. Bipolar, same thing. From a much more episodic to a much more chronic course. Outcomes are much worse today than they used to be. The other thing is, if you look at the disability data, it has a lot to do with the increase in bipolar. One of the ways you get an increase in bipolar is you put a lot of people on antidepressants. Some of those people will have manic episodes. They'll convert to bipolar. But here's the final word here. Again, this just came out. If we read this. The time has now come to call an end to the psychopharmacological revolution of 1952. That's when we get the first quote, antipsychotic. All revolutions have to come to an end, and the psychopharmacological one now has to meld into a quieter world where drug therapy will be joined by other approaches as equal partners, preferably working together in harness rather than conflict. Here's what I think we really need, what the science is telling us. We have embraced a paradigm of care that makes drugs the cornerstone of the care, right? We say, take your drugs, they fix chemical imbalances. And then over here, maybe we provide some psychosocial care almost as an adjunct, right? At least that's how it works in the United States. I think we need to make psychosocial care the centerpiece of what we do. Helping people relate to other people, build friendships, help them find meaning in life, help them find jobs and shelter. And then over here, we need to think about how can the best drugs be best used? And I think that's a question of figuring out for whom and for how long. And that the one-size-fits-all model that we have now really is not working. And the last thing I'll say is this. What's coming quite clear in certain research circles in the United States, they say, here are the problems with the drugs. You go on the drugs, and eventually your brain tries to compensate for the presence of the drug, and that causes changes in the brain, the opposite of what is originally intended by the drug, and it's called oppositional tolerance. And you'll see this is why we think the drugs antidepressants may be depressogenic over the long term. So that's the worry that has come up. The drugs cause the opposite of what is originally intended. And then the other problem is that they act like a trap. You go on the drugs, your brain has changed. Let's say you go on an antipsychotic, puts down the brake, your brain puts down the accelerator, now take away the brake. What do you got? It's really hard to go off. But nevertheless, if you live for a long time with the brake and the accelerator on, that may not be the best way for optimal functioning of that neurotransmitter pathway. So this is why I think, at least in certain circles, there's a sense we have to be much more cautious about the use of these drugs. I think everybody agrees they have a place, some place, can be a useful tool, but we need to figure out what is the place. Thank you.